Ruj will be the first one, right? So today we are talking about the common dislocation in orthopedics. So please focus in the practical point. Okay, you don't need to go in details about the surgery because it's too deep, but you need to know the how to do the examination, how to do the cross reduction, okay, and primary care. So let's start with Ruj.
Okay, so today's presentation will be about common dislocation in orthopedics, and I'll be the first speaker. And I talk about, and this is today's table of content, and I'll start with shoulder dislocation. So let's start with the anatomy of the shoulder. There are 4 joints of the shoulder: the sternoclavicular joint, the scapulothoracic joint, the AC joint, and the glenohumeral joint. But when we talk about shoulder dislocation, we look at the glenohumeral joint. It includes the articular surface of the head of humerus and the glenoid. And this on the right is the picture of the rotator cuff muscle, which associated with the shoulder dislocation. And this picture here is the capsulolabral complex, which also associated with shoulder dislocation. So shoulder stability includes dynamic stabilizer and the static stabilizer. For the dynamic stabilizer, it includes rotator cuff, the deltoid, the periscapular muscles, the long head of bicep tendon, and the joint proprioception. For the static stabilizer, it includes the articular anatomy, like the glenoid and humeral head, like I have stated before, the labrum, the capsule, and the ligaments around the complex.
So which one is more important in terms of shoulder instability? Static or dynamic stabilizer? Actually, both are important, right? But
yes.
Which one is more important?
I think it's the static.
Yeah.
Right?
Very good. The static stabilizer, especially the capsule labrum, okay? Capsule labrum and the ligaments. The most important ligament, which is, do you know which one?
I'm not sure. Sorry.
IGHL, inferior glenohumeral ligament. Okay? So labrum, capsule, okay, and ligament. These are the static stabilizer. And the IGHL is most important. So in case the patient have recurrent dislocation, the capsulolabral complex always torn, and the IGHL also torn. Okay. Okay, good. Next. But in elderly, it's different. This is in the young. But in elderly, the dynamic stabilizer is more important. Okay, go back to the slide. So which one is more important for dynamic stabilizer?
The rotator cuff.
Yeah, very good. The rotator cuff. So
because
in elderly, this location is different from the young. Okay, in the young, the problem is that the static stabilizer. The patient may have recurrent dislocation. For elderly patients, dynamic stabilizer always torn, like rotator cuff torn. Okay, and the recurrent dislocation is less comparing to the young people. Okay, very good. Next.
Next is the mechanism of injury according to the type of dislocation. So there are 3 types of dislocation. There are anterior dislocation, posterior dislocation, and the inferior dislocation. More than 90% is anterior dislocation. The mechanism of the fall is fall on an outstretched hand with aber position, which is abducted and external rotated and extended arm. Like you may, for example, direct blow from posterior humerus. For the posterior dislocation, a blow to the anterior portion of the shoulder. Axial loading of an adducted and internal rotated arm is like the opposite of the anterior dislocation. An example of incidence is a seizure or electrocution. For inferior dislocation, is very rare. We found it about less than 1%. It's caused by axial loading with the arm fully abducted and forceful hyperabduction of the arm, fall and suddenly grasp onto the object above their hand.
Okay.
But the history taking for mechanism of injury is very important because we have to look for the appropriate correlation, because sometimes patient might have hyperlaxity of the joint, like congenital things like Marfan syndrome and stuff. If this type of patient may have more very little trauma, but may cause dislocation of the shoulder, and the management is not the same as normal traumatic dislocation of the shoulder.
So why seizure in electric shock the patient have posterior dislocation?
Because when you have seizure or electrocution, the arm will be adducted and internal rotated, because the pectoralis major and latissimus dorsi contract, and it is very strong, and it makes the arm in the position that cause posterior dislocation.
Very good, very good. The LD and also the pec major is very strong muscles, so we have contracture of seizure or of convulsion. This muscle will pull the arm in adduction and internal rotation, causing axial loading and produce posterior dislocation. Okay, but it's not always. Some seizure abduction may produce anterior dislocation too. With dislocation, have the list of brachial plexus injury. Which one? Anterior, posterior, or inferior? Petra. Which one?
Anterior dislocation.
Anterior dislocation is also possible, but inferior dislocation, the humerus is going down to the axillary pulse, right? So the brachial plexus is very risky. So the inferior dislocation is most serious, right? Because if you imagine the head going down like this, right? Going down to the axillary area, so have high chance of the brachial plexus injury. Okay. How about anterior dislocation? What is the nerve at risk?
The axillary nerve.
Axillary nerve. Axillary nerve and musculocutaneous nerve, right? Okay, very good. Next.
Okay, so for the visual exam of the dislocation, I categorize it into two types of exams. It's the test for dislocation and test for instability. The test for instability is for chronic or recurrent shoulder dislocation, and I will show it in the next slides.
Yeah.
Okay. This is the test for dislocation. The first one is the Hamilton's ruler sign. It is normally you cannot the ruler cannot contact with the lateral head of the humerus and the lateral epicondyle, but when you have anterior dislocation, the ruler can touch both of the lateral the acromion and the lateral
so
epicondyle.
The ruler touching the proximal. Where is the proximal?
The proximal is the acromion.
Lateral border of acromion, right?
Yes.
How about distal?
Distal is the lateral epicondyle.
Yeah, okay. So in normal people, you cannot do this way, right? Because the muscles, deltoid muscles. Okay. But in this location, The head move antero-inferiorly. It's moved medially. You look at the pictures. Okay, it moved medially, so the deltoid will be flat. You see, deltoid flat. So you can put the Lurer on the lateral acromion and also the lateral epicondyle. Okay. Good. How about the Duga
Next
size?
is the Dugas test. The Dugas
Yes.
test is the procedure is make the patient seated and instruct him to touch the opposite shoulder with the head of 90-degree flex, and the examiner try to bring the elbow to the chest wall, and then the positive test is when the patient unable to touch the opposite shoulder because of pain. This indicate the dislocation of the humeral head.
So that for the anterior posterior dislocation, the Duga size.
This is for anterior dislocation.
Yeah, only anterior dislocation. Because the posterior dislocation, the patient will come to see you with adduction, internal rotation. Okay. So the Duga is only positive in anterior dislocation. Okay, keep in mind. Okay, next one.
Next is the anterior stability test to look for any like anterior labral tear. So we usually test it for instability of the shoulder joint. So
This is not for the acute dislocation, it's for the chronic
and
recurrent dislocation. Okay, because in acute situation you cannot perform this test, it's painful.
So so we basically put the patient in the Aber position and look for the apprehension sign of the patient's face. The patient may feel uncomfortable because we mimic the movement of the dislocation, and then
why the patient touch the examiner? Why?
Because he felt apprehension.
He feel
Like
pain.
Pain.
He feel like shoulder is getting out. Okay, so that's why he touched the examiner, because this is the anterior apprehension test. So you look at this, you see the arrow sign. So after the patient feel pain, so examiner push the shoulder to the back. You see that? So the feeling of pain is gone. Okay, we call this relocation test. Okay, go back again. Say it's pain. So the patient try to stop you, right? And then you push it back like that. The feeling of pain is gone. Okay, and when you release the arm, the pain come back again. Yeah. So this is the anterior apprehension and relocation test. Okay, next.
This is for the anterior instability.
Yeah,
Next
but you have to be careful, especially the patient that have the very loose joint. For example, you have a 10-time dislocation. If you do this test, the shoulder can easily pop out. Okay, and the patient have so much pain. So very careful when you perform this test. Okay, very gentle and very careful. Okay, next.
Next is the posterior instability test as well as the anterior instability test. This test is not for acute, it's for chronic or recurrent posterior dislocation of the shoulder. So there are two tests, the Kim test. Basically, he mimicked the position of the posterior dislocation of the arm, trying to adduct and internal rotate. And the positive is when the patient feel pain or feeling of dislocation.
So you need the axial loading also, axial loading, and cross the chest like this. Okay, cross it like this. So adduction, internal rotation. Okay. So that is for the posterior inferior, the Professor Kim proposed that test. The next one is the jerk test.
On the right one is the jerk test.
Yeah. Or the posterior apprehension test. So I perform the flexion, adduction, right? And internal rotations. And that way, okay? The patient will have pain. Then perform axial loading. The patient will have pain at the back of the shoulder. Yeah. We call this the posterior apprehension test. Okay, look next.
So next I'll talk about the associated injuries of the shoulder dislocation. For elderly patient, as I have mentioned, the most common associated injury is the rotator cuff injury, the axillary nerve injury, and the greater tuberosity fracture. But for younger patient, the injury usually occurs at the capsulolabral complex, which includes the labral tears or the fracture of the glenoid rim. Also, humeral head impression or Hill-Sachs lesion or tuberosity fracture. And I will show you about it more on the imaging so that you can see it. Next is the imaging. This is the imaging of the normal shoulder. As you can see here, in the transscapular wide view, the head of humerus is in the center of the Y, so there's no dislocation here. Usually we send AP view and transscapular Y view because the axillary view is painful in external rotation, in anterior dislocation, but we might send axillary view when we suspect posterior dislocation because we see it clearer when posterior dislocation.
So AP and transscapular is enough, right, for the anterior dislocation.
Yes.
Yeah, for the posterior, we often misdiagnose, right? So that's why we need axillary view, right, for the posterior dislocation. Okay, very good. Show the image.
This is the anterior dislocation. As you can see, from the AP view, you can see that the humeral head is out of the socket, and from the transscapular Y view, the humeral head is anterior to the Y.
Y shape. So the dislocation is not just anterior. So you're looking like three-dimensional. The head move anterior, inferior, right? And also medial. Okay? So that's why you can see the flattening of the deltoid. And if you look the arm will be longer than opposite side, right? Because the head is moving downward. Okay. And if the head moves very medial to the coracoid, you have higher chance of brachial plexus injury or musculocutaneous nerve. Musculocutaneous nerve is just medial to the coracoid process. Okay. Okay, very good. Next.
This is the picture of posterior dislocation. As I've told you, the AP view sometimes it is difficult to detect because this is like bulb sign, but sometimes it is not as obvious because in this picture you don't see the GT or the LT because it's turned.
Actually, the light bulb side is like the light picture. You look at the right picture. This is like light bulb comparing to the left one, right? Why? Because the arm is internal rotate. So you can see the head like light bulb because the head rotate, the articular surface move to the back. Okay. So another side is that you can see the joint space wider. Did you say that? The joint space is wider comparing to normal. So We call this the vacant glenoid sign. Okay. So sometimes you can misdiagnose, right? It look very similar to normal shoulder. Okay. So that's why you need axillary view, right? Look, you show axillary view to your friends too.
This is the
Axillary view.
is the view and the wide view for the posterior location.
Yeah.
As you can see, the humeral head is moving to the back.
Moving to the back.
And moving posteriorly in the wide
How
view.
can you know it's the back or the front? So what? How to tell it's back or front? Where is the clavicle?
Is
Is
it
it clavicle?
On the wide view, right?
Clavicle is
curves
in
towards
axillary view, right? Looking at the clavicle or coracoid process. So the head moves opposite side to the clavicle, right? You see clavicle? Ruth, can you show?
It's the ข้างล่าง
this one is clavicle. Okay, this is acromion, and this is coracoid process. Why coracoid process? Just close to. Oh no. Coracoid process.
Oh,
yeah, this one. Okay, that coracoid process and clavicle is in the front. So the head move opposite side. That means it's going to the back. Okay. For the wide view, sometimes it's not easy because it depends on you, the technician. Sometimes technician cannot make a nice wide view. It's difficult to interpret. Okay. But axillary view is very clear. Okay, next.
Okay, so this is the MRI of the anterior dislocation. As I have mentioned before, the associated injuries, the Hill-Sachs sign or the Bankart sign. The Hill-Sachs sign is the fracture of the humeral part of the humeral head, but for the Bankart side, it includes a soft Bankart sign, which is the soft tissue injury, and the bony Bankart sign, which is the bone structure of the anterior labral. So, as
I
I've
think your
mentioned,
friend may be confusing. It's very easy when the shoulder dislocate, right? The anterior structure will be torn because the shoulder dislocate to the front. So the structure in the front, there's a capsule labrum, and sometimes the bone is broken. If the bone is broken, we call this the bony Bankart, like the right picture, right? So when this is the head, this is a glenoid, right? So when it dislocates, the head moves to the front, right, like this. So the posterior part of the head attach the anterior glenoid. So that's a impaction. Head will be depressed by the socket, right? So the posterior part of the head will have the defect. We call this Hill-Sachs lesion. Okay. So when you reduce the head back, so that will be the depression fracture on the humeral head. So we call this Hill-Sachs. And the torn structure is in the front. So that is a Bankart. Okay. Bankart is a soft tissue, we call soft tissue Bankart. If there's bone, we call bony Bankart. Okay. Okay, good. Next.
Next is the management. I've listed indication for surgery, like frequent dislocation, fear of recurrent subluxation, high-risk activity, a glenoid bone loss, or large Hill-Sachs lesion or Bankart lesion, or unable to reduce. But for non-operative management, we do reduction. There are like many procedure for reduction, but the commonly used one are the Milch maneuver and the traction, countertraction.
So you need to do indication for surgery. For first time dislocation, most of the time we did not operate the patient. because we can wait and see, right? Some patient will not dislocate again. For the recurrent dislocation or the high-level athletes, okay, very risky activities like skiing, swimming. So these kind of patient may have the risk of dislocation. Okay, so we advise the patient to do surgery. Okay, for you, I think that's enough for the recurrent dislocation and the patient that had very risky activity. Okay.
This is the Milch maneuver, and I'll show you the video.
So this procedure can do under sedation. Okay, you can sedate the patients. Or some patient, if they have multiple dislocation, it's very easy to reduce. So traction and slowly abduction, and then slowly supination. Okay, so you slowly supinate the arm, right? So now it's reduced already. You ask the patient, the pain is gone. Okay, and you can put the arm to opposite side like you do dukkha, right? So if the patient can do that like this, that means the shoulder was reduced. Okay, so this is very simple and easy. Mills maneuver.
The next maneuver is called traction countertraction. As the last one, we sedate the patient first, and then we perform with one side traction, countertraction.
So this is also under sedation. We give diazepam to the patients or Valium pethidine, right? So after the patient feels sleepy, then we can perform this. So in case the patient have the rotator cuff tear or tuberosity fracture, we need the second force. Okay, so this is a modified traction countertraction. Because if you have no rotator cuff or torn rotator cuff or tuberosity fracture, that we know muscle pull the head back to the socket. So this force, okay, you see that I put the towel for proximal arm to make to help the reduction. This will help in case the patient have the tuberosity fracture or rotator cuff tear. Okay. So I advise you to do this because this maneuver is quite safe.
So about the last part is advice and rehabilitation. Advise the patient to avoid motion causing the dislocation like ABER position or adduction internal rotation in posterior dislocation, and advise the recurrent risk of this dislocation. The younger the patient, the higher the recurrent rate. For under 20 years, the recurrent rate is about 90%, and for over 50 years, the recurrent rate is about 20%. So, but for the rehabilitation, we make the patient do the with the arm sling for 1 week, and then do the rotator cuff exercise to strengthen the joint. Okay, so that's all about shoulder dislocation.
Good. And you advise the patient about the position that may produce dislocation also, right? Because sometimes you just reduce and you did not educate the patient will come back again, right? So always tell them that they have a chance to dislocate again, especially the young patients. Okay, 90% is very high. Okay. Okay, very good.
Thank you.
Any questions? Shalita วิชัยยุทธวิชยุทธใช่ไหมวิชยุทธ
ใช่ครับอาจารย์
Any question from you? No,
not yet ครับ
not yet. Okay, thank you. So very good.